Influenza prevention, brought to you by Fluvir from Heathrow. Heathrow Healthcare, as you know, is an innovative pharmaceutical company. Our journey began in 1993. We have 30 years of excellence with 36 state-of-art manufacturing facility. We have 300 plus products in our portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We are Asia's largest manufacturing complex at Visakhapatnam, Andhra Pradesh. Whilst Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide range of products encompassing multiple specialties. Pioneering in quality and innovation, we have distinction of bringing 4 biosimilar products to market within 5 years of initiation, like darbepoetin, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir, for which we received an award of Pharma Excellence in August 2020 for COVID drugs. Today, the webinar is on influenza and risk prevention. We all know that influenza is a condition which you can prevent, it will be very good. And we all know the role of oseltamivir. But to share their experience on the role of oseltamivir in prevention of influenza, today we have got eminent speakers with us, Dr. Rajendra Salagare and Dr. Nageshwar Narayan Rao. Welcome, sir. Dr. Rajendra Salagare is MD from Bangalore Medical College, is consultant pediatrician, Salagare Children and Hospital, Belgavi. EB member, CIIP 2023, President Belgavi IIP 21-23, Vice President Karnataka IIP Belgavi Division 2021, Advanced Life Program. Sir has performed several procedures both in neonates and in children. Dr. Rao has done presentations in many seminars and conferences. Welcome, Dr. Rao, and I hand over the session to Dr. Rajendra and Dr. Nageshwar. Over to you, sir.
Thank you, sir. Thank you.
I'll stop sharing.
Shall I share now?
Yes, yes.
Okay, shall I start now?
You'll start. Okay.
Yes, sir. Yes, sir.
Okay. So, good afternoon, everyone. I thank Heathrow Healthcare for providing an opportunity to speak few words on oseltamivir and especially in flu management. Next slide, please. So in the coming 15 to 20 minutes, we are going to have a small discussion on healthcare challenges which we pediatricians face in monsoon and in their diagnosis. Also, we will try to know few things about the influenza and its complication, the oseltamivir, and how the drug has to be used, and what are the guidelines recommended for the empiric use of oseltamivir. As we know, like flu or flu-like illness can range anything from a simple acute febrile illness to severe pneumonias and even death. So this is a wide spectrum of the disease where the simple flu virus can cause based on the host immunity level and host response to the influenza virus. Next slide, please. Coming to the dynamics of occurrence of influenza in relation to seasonal variation in Chennai, as we know that the flu is usually a seasonal disease, a study was conducted in Tamil Nadu, which was a cumulative study of 7 years. This study started somewhere in 2011-2012, and the complete results were published in 2019. And this study was conducted in King Institute of Preventive Medicine and Research. Among these 7 years, 36,670 samples were subjected to influenza analysis over a period of 7 years. And during this study, they have found that influenza positivity started with the onset of monsoon and peaks during the post-monsoon months. So hence this study gives an indication like when we in our practice should think about the influenza positivity in our routine OPD hours. Next slide. So coming to overview of influenza in India, how is the burden of disease and how much is the burden of disease? There are two bar diagrams here. One is showing the cases of influenza infection and the second is the deaths which have occurred due to the proved influenza infection. There are some many cases which go undetected when the patient does not reach to a tertiary level where this exact diagnosis cannot be made. When compared to the years of 2015, 2018, and 2019, we have seen that in 2015, 4,259 cases were detected to have influenza. Among that, 299 deaths have occurred. It approximately comes to around 7%. Similar ratio can be seen in 2018 also, whereas in 2019, the ratio has come down to 4%. It means that among the documented cases, the mortality can be as high as 7%. Uh, among the influenza. Next slide, please. So influenza, as we said earlier, influenza can occur as a simple acute febrile illness to a severe disease and even death also. So influenza is one of the most common infectious disease caused by influenza virus, and it is being very highly contagious airborne disease that occurs in seasonal epidemics and manifests as acute febrile illness. Next slide. So coming to the type of influenza virus, like influenza A, we have to remember mostly influenza A only because this is the main culprit in causing the serious form of the disease. And this influenza A occurs in frequent epidemics as well as periodic pandemics. Whenever it occurs as frequent epidemics, it is due to minor antigenic variation. Whereas the major periodic pandemics occur due to major antigenic drifts. Influenza B virus, it can infect only humans and it causes only local epidemics. We don't find pandemics in case of influenza B. Whereas influenza C, it is one virus where it can infect both humans as well as swine. So influenza type C infection generally are known to cause only mild respiratory illnesses. And mostly the circulating human subtypes are H1N1 among type A and H3N2 viruses. So these are the viruses which has to be given more importance in identifying. Next slide. So transmission of flu virus, yes, we have to know this mode of transmission because this is how we counsel the parents to avoid the transmission. So flu viruses, people who are infected with flu can spread it to others up to 6 feet away. As we have during COVID days, we said like we have to maintain 2-meter distance or 6 feet distance. This was to avoid this airborne transmission. Again, flu viruses are mainly spread by droplet infection, which are generated through coughing, sneezing, talking, screaming, so many things. In our OPD, a lot of babies do cry because of anxiety. These droplets can land in the mouth or nose of the people who are nearby and are possibly inhaled into the lungs when they are suspended in the air for longer time. So people should stay away from the affected person, or we should ask the affected person to isolate himself and stay at home if he is very sick. It is also important to follow the proper hand hygiene. Most healthy adults who are able to infect other people is not after the start of the symptoms, but one day before the appearance of symptoms. So their infection, the capacity to infect others has started before one day before the actual occurrence of symptoms, and this may extend up to 5 to 7 days also after becoming sick. But in case of children, the virus may persist longer, and the children tend to transmit virus for a longer duration of more than even 7 days. Next slide, please. So potential triggers for what are the factors which triggers influenza infections are? It is like peak rainy season, where a different species like bird and swine, like we saw in influenza type C, poor quality index due to metro cities having high pollution, and in case of immunocompromised hosts. These are the factors which give boost to the influenza infections. Next slide. So this is a symptomatic differentiation of ILIs like influenza-like illness, H1N1, SARI, and COVID-19. In almost all 4 types of infection, fever, myalgia, cough, lack of energy, and sore throat, these 5 common symptoms are common in all the 4 types of infection. Whereas breathlessness may or may not occur in acute influenza-like illness, but it is definitely present in H1N1, SARI, and COVID-19. Any patient presenting with flu-like symptom having breathlessness, you should think about H1N1, SARI, or COVID-19. Similarly, loss of smell and loss of taste, we have heard so many times like in COVID it occurs. And diarrhea, yes, it is present in COVID-19 type of infection. And headache may or may not be present. It is like an associated symptom in all the 4. Next slide, please. So here we, during our busy OPD schedules, we should search for the emergency warning signs for triaging of the patient. In children, if you find like child is having fast breathing or trouble breathing, if there is cyanosis, that the child is not taking orally and it is excessively lethargic or being irritable that the child does not want to be held, the flu-like symptoms improve but then return with more severity, or child presenting with fever, rash. These are the children we need to monitor for severe flu-like infections. Whereas, in addition to that, in infants, if the child is not able to eat or feed, has troubled breathing or increased work of breathing, they has no tears while crying. It is like excessive cry and significant fever with oliguria, like decrease of urine output. These are the warning signs in infants. Whereas in adults, yes, we need to know symptoms in adult also because they can transmit infection to children who are present at home. Any adult or an adolescent who is having difficulty in breathing or shortness of breath with pain or pressure in the chest or chest tightness or abdominal tightness, sudden dizziness, confusion, severe or persistent vomiting, and flu-like symptoms which are going and coming. So these are the warning signs or direct questions we have to ask to patient in our OPD to rule out the warning signs. Next slide, please. Complications of flu, like it can vary from simple influenza-like illness to death. So many things can occur, like pneumonia, bronchitis, ear infection, worsening of the existing disease in an elderly or immunocompromised patients, and your acute respiratory distress syndrome. Next slide, please. So to the knowing the severity of influenza, now the patient does not come to us to know all those things, but they come for treatment to us. So coming to treatment of influenza treatment is supportive and definitive treatment. Supportive treatment include we should ask patient or a child to have bed rest or rest at home, increased fluid consumption to maintain adequate hydration. If cough is severe, then we can add some amount of cough suppressant based on the child's age and weight. Antipyretics and analgesics like simple paracetamol can be used. If the child is not responding to paracetamol, or even in adults, we can go for NSAIDs for fever and myalgias, not for kids. And most patients with good immunity recover in 2 to 3 days with symptoms. However, malaise and body pain weakness may persist for 2 to 3 weeks also. Severe cases, if you find like child is toxic looking, dehydrated, oliguria is there, warning signs are there, in those cases you prefer to give IV fluids and other supportive measures. Next slide. So this was about the supportive treatment. Now coming to the definitive treatment, we should go for antiviral drugs. Antiviral drugs, as we have studied in pharmacology, it can be neuraminidase inhibitors or adamantanase channel blockers. Here we will try to remember only two drugs in each group. Neuraminidase inhibitors, they block the viral neuraminidase enzyme, which is critically releasing the virus from the infected host cells. And by preventing this neuraminidase enzyme, we are preventing the viral replicas to burst into the bloodstream and infect the other cells. So these neuraminidase inhibitors are active against both influenza A and influenza B. When you are in doubt whether it is influenza A or B, better to start with neuraminidase inhibitors. Examples of neuraminidase inhibitors are oseltamivir and zanamivir. Coming to the other group of drug where it is the M2 ion channel blocker. This drug is active only on influenza A, and the mode of action is by interfering with the hydrogen ion channel activity of the influenza A virus, thus blocking its entry into the host cells. So this drug doesn't allow the virus to enter into the host cell itself. Again, the examples of those group of drugs are amantadine and trimetadine. Next slide, please. So how to, once we have diagnosed, once we have shortlisted, like we have to give oseltamivir to a kid, then how to proceed, how will be the dosing and how many days to do. So oseltamivir, as we know, it is effective against all strains of influenza type A and type B. If you don't know which virus is affected, if it is immunocompromised, you don't want to take risk, then oseltamivir can be tried for influenza and A and B. So it not only decreases the viral load, it also prevents spread of infection by neuraminidase inhibitor. So oseltamivir drug itself is a prodrug. Once it enters into the body, once it enters into the bloodstream, it is metabolized into the active form called oseltamivir carboxylate in the liver. Then its action starts. So the action is by again neuraminidase enzyme inhibitor of the viral. Next slide. So this is the image showing how this oseltamivir acts at various levels. Next slide, please. So oseltamivir is the first oral neuraminidase inhibitor, and the drug is so famous and like a safety profile is well established. Like it has been approved in more than 100 countries. Next slide. So coming to the dosage of recommendation, in adults it is easy to titrate the dose because they have one standard fixed drug combination. But in pediatric, we tend to deal with babies as low as 1 kg to adolescents somewhere 30, 40 or even 55 kgs. So we need to know the drug dosage for each age level. In adults, it is standard 75 mg capsule is available. Advise them to take twice daily for 5 days if it is for a treatment. Whereas if it is for a chemoprophylaxis, advise them to take 75 mg tablet once daily for 10 days. Whereas in children, if the child is less than 15 kgs, you can give it as 30 mg per kg per dose in 2 divided doses. For all the treatment part, oseltamivir treatment, we have to give it as BD, whereas in prophylaxis, you have to give it as 40. Between 12 to 23 kgs, it is 90 mg per day in 2 divided doses, rather 45 mg per kg per dose. Between 23 to 40, it is 60 mg per kg per dose, and more than 40 kg, it is 150 mg per kg per day or 75 mg per kg per dose. When the child is 40 kg and above, we can coincide with them with the adult dose. If you encounter an infant ranging from 2 weeks to 1 year, then again the dose has to be calculated as 3 mg per kg dose. Or if you want to give it in ml, then 0.25 ml per kg. Because the syrup is available as 12 mg per ml, that is 60 mg per 5 ml syrup is available. And it is advised to that oseltamivir should be initiated within 48 hours of onset of symptoms so that the drug works effectively and the symptoms get in control as early as possible. In the future slides, we are going to see the diagram where oseltamivir was started early and the response achieved was also early. Next slide, please. So what oseltamivir can be told as a wonderful drug for walking pneumonia. So this is one of the case study of adult. Then we'll try to see other slide because we will deal more with pediatric. Next slide. Next slide, please. So this is one X-ray where you find bilateral interstitial infiltrates with the high-grade fever, toxic-looking child, breathlessness, not feeding, irritable child, drowsy child. You should consider viral pneumonias. Next slide. Again, this is a same case study where they have said that oseltamivir has improved the patient's condition. Next slide, please. So they have conducted a retrospective study where after starting oseltamivir, there is a reduced occurrence and severity of pneumonia due to H1N1 by early oseltamivir administration. Here they have done study in 442 patients with the oseltamivir administration of an appropriate dose for 5 days, where they have found that the subjects were divided into 4 groups based on the time when the oseltamivir was started. Whether it is less than 2 days, between 3 to 7 days, 8 to 14 days, or more than 14 days after onset of symptoms, they have started oseltamivir. Next slide, please. Here, this graph is showing that when we have started oseltamivir early, we have there was a decreased incidence of pneumonia, complications, and also recovery was fast in a group of population where we have started the oseltamivir in the early part of infection. Next slide, please. Again, this is a graph where it shows the patient with a shorter time to oseltamivir administration were discharged earlier from the hospital. Next slide, please. So we are in a dilemma sometime whether it is bacterial, viral in the early part of infection. There they have conducted one more study where they have added oseltamivir along with azithromycin as a combination therapy to reduce secondary bacterial infection. So in this retrospective observational cohort study, what they have done is they have divided the influenza A infected and hospitalized patient into two groups. For one group, they have given oseltamivir and azithromycin for at least 3 to 5 days, and number of patients were 227 in this group. Other group received only oseltamivir for 3 to 5 days, and that group of patients were around 1 or 2 in number. Next slide, please. In this, what they have seen is incidence of secondary bacterial infection, because as these were hospitalized patient, not an OPD patient, the incidence of secondary bacterial infection was significantly low when they have administered oseltamivir and azithromycin as a combined therapy when compared to the control group. Next slide, please. So, if you find or if you feel like there is a chance of secondary bacterial infection, then azithromycin and oseltamivir combined therapy gives much superior results when compared to oseltamivir alone. Next slide. So, after seeing all this, what does WHO has to say about oseltamivir? When you find when you encounter such a situation where you can't diagnose whether it is influenza A or B, child is sick, and if you have a strong indication of oseltamivir, better to start empirical treatment, and it is strongly recommended. Treatment should be started as soon as possible. It is because we have seen in previous slides when the oseltamivir was started in the early part of infection, the what we call morbidity associated complication and recovery time was much better when we started early. So lab confirmation of influenza virus infection is not necessary for the initiation of treatment. If you suspect, send the sample, and in the meantime start the oseltamivir. In the meantime, you will get the report. Negative lab test of H1N1 does not exclude the diagnosis in all patients. Therefore, early starting of oseltamivir is recommended when you strongly suspect H1N1 or influenza-like illness. And if you encounter high-risk individuals, like children who are immunocompromised on nephrotic syndrome, post-chemotherapy, severe acute malnutrition children, then it is better we start early once you find like it is flu-like illness. Next slide, please. So, an empiric supportive therapy and monitoring. What does Government of India, Minister of Health and Family Welfare has to say in this regard is give empiric antimicrobial. It is antimicrobial here. In this situation is antiviral to treat all likely pathogen causing SARIs. Empiric antiviral treatment should be based on the clinical diagnosis, like whether it is community acquired pneumonia, healthcare associated pneumonia, or like a seasonal flu infection. Since empirical therapy should include a neuraminidase inhibitor for treatment of influenza when there is a local circulation and other risk factors, like there is history of travel is there, exposure to animal or influenza virus is there, any of the family member who is affected severely with flu-like infections, SARIs. So in those situations, you have to consider empiric therapy. Next slide, please. So this is in adults and community-acquired pneumonias where who has tested positive for influenza. Should the treatment regimen include antiviral therapy? So recommendation says we have to give influenza therapy with oseltamivir for adults with community-acquired pneumonias who has tested positive for influenza in the inpatient setting, independent of duration of illness before diagnosis. If the patient has presented to you around 4th or 5th day, like when we have seen in previous slide, it works better if you start on 2nd or 3rd day. But in that situation, whenever you first come in contact with the patient, even it is little bit delay, you have to start it in inpatient settings. Similarly, observational studies suggest that treatment with oseltamivir is associated with reduced risk of death in patients hospitalized with community-acquired pneumonias who has tested positive for influenza virus. Similarly, treatment within 2 days of symptom onset or hospitalization may result in the best outcome, although there may be benefits up to 4 to 5 days after the symptom begin. But if you see a patient on 4th or 5th day, you should not delay or stop that oseltamivir. If you find there are risk factors, then you better start on even 4th or 5th day also. Next slide, please. So to summarize, proper diagnosis and initiation of early treatment can prevent flu complications. Empiric use of oseltamivir reduces lower respiratory tract complications, hospitalization due to lower respiratory tract infections, and also high-end antibiotic use. So, the World Health Organization, American Thoracic Society, and Minister of Health and Family Welfare recommends empiric use of oseltamivir wherever you find the at-risk population or at-risk children. So again, the decision to start oseltamivir is clinician-based. If you find like warning signs are there, at-risk population is there, immunocompromised hosts are there, it is better to start oseltamivir on an empiric therapy. Next slide, please. So this was in short about the oseltamivir and the flu viruses and their modes of infecting individuals and the complication of the influenza virus and how to prevent and how to treat them. Thank you.
Thanks, sir. It's very interesting. One thing I want to ask is how common is the respiratory syncytial virus?
RSV, yes, sir. I practice in Bidar. We have some facilities, nearby facilities around 130, 140 kilometers from Bidar, it is Hyderabad. We have facilities where they do respiratory panel. We do get children who are
RSV.
infected with RSV. We have tried many modes of treatment, even oseltamivir also.
Oseltamivir will not work there, no?
Oseltamivir, some children do respond, sir. Some children who do not respond, we have sent them there. They have done swab test and respiratory panel test. There they have started ribavirin and the child got discharged in 48 hours.
Yeah, because ribavirin is very specific for RSV.
Yes, yes.
And how common is RSV as compared to H1N1 and?
Like it is all seasonal, sir. Once that RSV epidemic start, like it gets
epidemic, entire population getting infected. Right. And I mean, this may not be specific to viral, but how common is atypical pneumonia in children? Mycoplasma.
Like in November and December these days, we are getting pneumonias and lot of consolidations. Last 2 children who came with empymas, we had got bad smell.
Then you start azithromycin with them or higher antibiotics still?
It presented late to us, sir. When I saw them in OPD, it was increased work of with high-grade fever. Initially, we gave first aid. Then we got an ultrasound. Then we found like multiple locals of empyema there. We sent them. Child got operated. Now it is fine. They are getting discharged tomorrow.
Absolutely. Good.
In the earlier point of infection, yes, it is better to start azithromycin with oseltamivir.
So, do you think over a period of time, the incidence of viral infections has increased, especially after COVID, the incidence of viral infections has increased as compared to bacterial infections?
Like it depends, sir. Like
not like that. It has happened.
Like it is again seasonal, sir. In one season we get more of viral infections. As before COVID also, like now the parents are aware, hygiene status has increased.
Yes.
A lot of awareness we are creating about flu vaccination. So complications related to flu vaccine infections have come down, sir.
That's correct. And flu vaccine does help in some way to
definitely.
Reduce that. Thank you, sir. Thank you so much. Thanks for your, Thanks, Dr. Rajendra.
Thank you.
Yes. Thanks all the participants who took time from the schedule and attended this. Anything, I mean, it is there, then we can definitely will come back to you for your opinion. Thank you, sales team, and thank you, marketing team for conceptualizing this and follow up. Last but not the least, thank you, IT team for your IT support. Thanks, Srinivas. And just 1 minute. I'm sorry, Dr. Salagare, you have to present some case studies. Samriddhi was telling me.
Yes.
Please share the screen, sir.
Someone is sharing. I think stop this.
She's sharing. Are you sharing, Samriddhi?
No, I've stopped sharing, sir.
No, Dr. Salagare is sharing.
Yeah, now.
I'm sorry, I was not aware. Dr. Salagare is also present.
Screen is visible?
No, sir.
No?
No.
Yes, sir. Now?
No, sir.
So make it full screen. So maybe because after that you'll be able to see.
Screen sharing has been paused.
Yeah, we can see now. It's visible, sir.
Okay. Thank you, Metro company for giving me this opportunity, and I thank Dr. Nageshwar Rao for initially briefing about almost all he has covered. So he has briefed about the influenza and its drugs management, the oseltavir, everything he has covered. Few aspects of clinical side regarding this flu. As everyone knows, this is the very age-old disease, and this used to be act as the population control measure. Like every year, it used to have its toll. Even now in Western setup, they lose millions of, there's especially vulnerable age group, that is above after 60 old age people as well as younger generation. Luckily, with the advent of vaccine and the effective drug, so the incidence of this morbidity and mortality is coming down. So we'll see some few cases, case reports. So already Nageshwara has covered this influenza-like illness, H1N1, severe acute respiratory illnesses, and COVID-19. So we'll have first case here. A previously healthy 6-year child was admitted to emergency department with fever, vomiting, weakness, ataxia with febrile seizures. On admission, his physical examination parameters were as follows. Weight was 22 kilo. He was around 50 to 75 percentile. Height was 117 centimeter, 50th percentile. Temperature was 38.2 degrees centigrade. Heart rate was 110. Blood pressure was 110/65. He was conscious on examination. Cranial nerves were normal. The tone and power of the muscles were normal. Deep tendon reflex were intact, and there are no meningeal signs, and Babinski sign was negative. Clinical and neurological examination revealed he had a broad-based ataxic gait. There was hypotonia, poor coordination, truncal titubation, positive Romberg sign. There was dysmetria as well as dysarthria. He was investigated. His blood count was 9,350 with a neutrophil that is 68%. Hemoglobin was 11 grams. Platelet were 2.5 lakhs. And CRP was less, that is a negative, almost 0.1 milligram. And the ESR was 21. So there are biochemically, there is a serum, the LFT, RFT, electrolytes were normal. CT of the brain was normal. CSF analysis was done, which was normal. The protein sugar were normal, and CSF cultures were also bacteriologically sterile. The PCR of the CSF for the influenza, herpes simplex, adenovirus, entero, CMV, herpes 6, HS, that is HS6, Epstein-Barr virus, varicella zoster, all were negative. Again, then when MRI was done, MRI was also normal. Serological tests for the, again, all these viruses were negative. The viral panel, including CME, measles, mumps, rubella, and the extended panel, including the human metapneumovirus, coronavirus, were not detected. However, his H influenza, that is influenza H1N1, was detected on third day because the swab was taken at the time of admission, and oseltavir started twice a day, and the child recovered. We have a second case, that is 10-year boy present with moderate fever, cough, and occipital headache since 5 days, and one episode of generalized tonic-clonic convulsions. There was fever just before admission. These seizures occurred just before admission. Immediately after admission, he developed right-sided focal convulsions, which were controlled with intravenous midazolam. On admission, the child was febrile with blood pressure of 110/70, heart rate was 82 per minute, and respiratory rate of 24. His SpO2 was 97% in room air, and blood sugar was 96 milligrams. He was drowsy, Glasgow Coma scale being 10/15. Pupils were 2 mm, bilaterally equal and reactive. There was some terminal neck stiffness was present. The rest of the CNS examination were normal. So routine hemoglobin, blood gas, and serum electrolytes were normal. Against serum LFT, RFT, that is investigations were negative, normal. CT was performed, which showed ill-defined hyposensitivities in the subcortical white matter in the posterior parietal lobes bilateralis, that is suggestive of encephalitis. Lumbar puncture for CSF analysis was done, which showed now 40 cells. Proteins were normal, at 48 milligram, and glucose was also normal, 71 milligram, and no organisms on the Gram stain. So it's nothing like it was like a septic meningitis. The chest X-ray revealed small focal consolidation on the right lower zone. Nasopharyngeal aspirate specimen tested for H1N1 by RT-PCR tested positive. So but CSF was negative. So CSF for herpes simplex was negative. So this child again was started on oseltamivir because it was the swab was positive, and then he recovered. One child, this is a 15-year boy, is male, 40 kg. He had fever once daily for 2 weeks. There was chest pain and there was no cough. Chest X-ray showed bilateral opacities with right-sided mild pleural effusion. So admitted and put on ceftriaxone. That is a routine practice. So then next, but the fever continued. His investigation revealed HB was 11, total count was normal, that's 10,200, with the predominance of neutrophils, lymphocytes being 32, and CRP was high, 84 milligram. Sputum was tested for because 2 weeks, so AFB was tested, CBNAT was sent, and Mantoux test was done. So, but CT scan showed right lung diffuse interstitial reticular fissular bronchovascular and septal thickening with mild pleural effusion. Chest X-ray during admission, this was the pattern, and there was bilateral infiltrated sign more on right side, and that is day 7, which there was localized with pleural effusion on the right side. So day 5th on admission and day 7th of fever, still the child was persistently febrile. There are no seizures. Cough is increasing. Oral intake is not satisfactory. So the antibiotics were escalated to piperacillin, tazobactam plus amikacin plus oral azithromycin, as he was in ICU, was not doing well. Parents were worried. So then the even consultant starts scratching their head. When there is no option, the empirical oseltamivir was added after taking throat swab. Then suddenly, the child started recovering. CRP was become 82 on day 7 and 41 on day 10. He became febrile after 7 days of admission, and his other investigations were normal. That is, Mantoux was negative. Respiratory panel sent, that is H influenza. So the global H influenza study that included 18 lakh 20,000 influenza cases from 31 countries during 2000 to 2018 reported, that is around 23% cases of influenza type B. So it is a major disease affecting worldwide. There are, as expected, there are cases from United States, that is 54%, and Australia contributed to the maximum number of cases. In countries of the southern hemisphere, influenza A epidemic peaks in July-September and influenza B peaks in August-September, though it is difficult to differentiate them clinically. In countries of northern hemisphere, influenza A peaks on January-February and influenza B peaks in February-March. However, there is again exception to this pattern in some countries. In most countries, influenza B Victoria showed unimodal curve with the peak below 10 years of age. So in tropical countries, timing of influenza A and B epidemics differ. There appears to be no consistent pattern that is in our region. It is our region. So there are no consistent pattern in timing of the different epidemics. That is, influenza type B, Victoria occurs more frequently in tropical countries, while B, Yamagata occurs more frequently in temperate climates of the southern and northern hemisphere. This is something. So this study already has been discussed by Dr. Nageshwar Rao. 2-year child admitted with cough for 5 days. There's a dry cough, cold for 4 days, fever 3 days, very high degree. There was grunting. And on examination, heart rate was 120, respiratory was 35, and there was tachypnea. Bilateral Krebs and bronchi were there. So provisional diagnosis, as usual, that is LIT1, lower respiratory infection was done. Investigation revealed HB was 11, total count were 11,500. That is, here the lymphocyte predominance 72% and polymorphs 26%, with eosinophil and monophils 2% each. Platelet were 2.46 lakhs, CRP was 9. So this is the X-ray, classical, that is bilateral infiltrates, hilar infiltrates. So he was started on IV antibiotics and along with nebulization with salbutamol. His tachypnea reduced, but on day 3, patient was drowsy, he was sick and not accepting feeds. So suspecting, because when child is not responding to routine antibiotics, we should think of something else rather than antibiotic resistance. So it was rightly thought and that is throat swab was done, which grew, that is H1N1. So the child was, instead of going for higher antibiotics, started on oseltamivir, and the child improved. So though in clinical practice it is difficult to differentiate between bacterial and viral, but it matters a lot. So there are some clues to differentiate viral and bacterial infections, especially for respiratory infections. In viral fevers, usually the onset is acute and the cough is predominant symptom. The cervical lymphadenopathy is less common, and there are associated symptoms. Usually virus involves multiple systems at a single time. There is rhinorrhea, there is a exanthema, some cases have exanthema, there is rash, there is hoarseness of voice, some cases have diarrhea, some cases have conjunctivitis. So there is other symptoms are common in case of viral infections. And the local examination, there is pharyngeal only redness will be seen in viral. Whereas if you go for bacterial, the fever is high grade on day 1 of symptoms. It is gradual rather than acute. And cough is usually absent in bacterial infections. And there will be associated cervical tender lymphadenopathy if there is upper respiratory larynx or tonsils are involved. There are associated symptoms are usually uncommon because usually single system is involved in bacterial infections. Local examination may reveal if there is tonsillar involvement, that is thickness, thick exudates, purulent and patchy tonsils may be seen. There is some clinical, that is parameters to differentiate bacterial and viral. Look at one more case, that is case number 5. A 14-year boy who with no underlying comorbid condition was referred to the tertiary care institute with presented with low-grade fevers, throat, myalgia, and so there is myalgia and throat for 7 days. There was no breathlessness, vomiting, or diarrhea. Before referral, he had received antibiotics in the form of ceftriaxone and piptas without any improvement. That means he has already started on IV antibiotics, higher antibiotics, but he is not responding. So, as I said earlier, rather than going for changing the antibiotics and thinking of antibiotic resistance, we should revise our diagnosis. So this child had mainly low-grade fever and there is no breathlessness and cough. So this is classical for, that is walking pneumonia, what we call as. The child is, but if you see the symptoms or if you take the findings will be more, but clinical symptoms are very few here. So in such a case, there are only 2 diagnoses, usually atypical pneumonia caused by chlamydia or mycoplasma, and the other one is it is pneumonia caused by H1N1. So the drug of choice will be again here, oseltamivir. And when you have a doubt, you can, as already Nageshwar has told, that you can use both combination, azithromycin as well as oseltamivir. So it will reduce the chance of resistance as well as the chance of early recovery. So oseltamivir already is a drug of choice for this walking pneumonia. So on examination, his vitals were his pulse was 110, blood pressure was 110, 72. Temperature, he was febrile. There was bronchial breathing, bilateral coast circles in the inflammatory region. There was X-ray wise, mid-zone interstitial infiltrates on a chest radiograph, and nasopharyngeal test swab was taken. PCR of which revealed the H1N1 type A virus. C-reactive protein was very low, it is less than 10. Here, the X-ray findings are more than his symptoms. So that is why it is called walking pneumonia. His cardiovascular, abdominal, CNS systems were normal. Laboratory evaluation, that is especially these total counts and were almost normal. Liver functions and kidney functions were normal. So this is the picture already, it has been shared. But the X-ray findings are more here. There is almost bilateral involvement of the lung with the patchy infiltrates. So, at some densities. So this goes for interstitial pneumonia, which is classical for this H1N1 pneumonia. So the oseltamivir dose already this has been discussed by Dr. Nageshwar. So this is why already few topics have been covered here already. So the H influenza is one of the common infectious disease caused by H influenza. It is highly contagious. And it can cause to this has been already discussed how it spreads. So these parts I think covered. So the major complications of flu could be could be, that is pneumonia. It can cause bronchitis. It can cause ear infections. It can cause worsening of the disease like asthma, COPD. It can cause ARDS, can cause death and pneumonia. So these all complications can be prevented. One is early diagnosis. Second one is using all the precautions, hand hygiene, and keeping oneself clean. Third thing is the effective vaccination is available. Should make use of that. And fourth thing is diagnose early, because almost all government setups now provide facility for this H1N1 test, that is influenza testing. So those job is can be sent and investigated. And when in doubt, when child is sick, better to start empirical consultation rather than waiting for the diagnosis. Thank you.
Thanks, Dr. Rajendra. One more thing I wanted to know, sir, this the conversions that people get. I saw two patients associated. They had the similarly conversions along with the fever. Are they febrile conversions, or were they febrile conversions, or they were
They were febrile only.
febrile only?
One case was febrile seizure because his CSF was normal. Other
Okay.
had aseptic meningitis-like fever because he had his CSF revealed cells.
Okay.
It was like a viral pneumonia, viral meningitis.
And so secondly, what I wanted to ask is, how commonly in viral infections, the fever shoots up to 103, 104, unlike bacterial infections?
It shoots up, sir, especially early phase of when there is acute fever. Sometimes the fever shoots up very high.
Okay.
Not there is acute when sudden.
Yeah.
That's comes as a sudden. Whereas bacterial starts with a moderate degree and then when child is sick. Whereas viral fever, in spite of the 100 temperature being 102, 103, child is plain. So there is
Okay. Generally, I mean, it's said as a walking pneumonia.
Yes,
Generally,
sir.
it's not supposed to be. I mean, the symptoms are supposed to be lesser than the.
Drug upstairs.
Yeah. Anyway, thank you very much, Dr. Salagare. I'm sorry, I did not know your case were presented. And thanks once again, all of you, for attending this. Thank you, IT team. And thanks once again. Signing off. Thank you. Thanks, Srinivasa.
Thank you. Shall I leave?
Yeah. Yes, sir. Thanks, Samruddhi.